Fitting guides and tips for the bivalve TLSO or the clamshell TLSO. It will be referred to as multiple things in the chart. It's by far the most widely used orthotic device on the neuro floor. It's used for a number of pathologies, both trauma, fracture, infection, and post-surgically. Its functional range is T8 to S1. Very commonly used for multi-level PLIFs where the neurosurgeons are wanting some post-operative stability and security and safety. Also aids in comfort and pain control after a large procedure. It's also used for compression fractures from falls, motor vehicle accidents, burst fractures, any other type of orthopedic involvement of the spine where stabilization is needed. Similar to the Aspen LSO, it's imperative that the device is donned in the supine position or the patient lying down. We want the spine to be unloaded. We want the spine to be long and lean before applying this device. We also want to be able to control the tissue a little bit better, especially when we're trying to cover up as much of the torso as we are with the TLSO. So the next, we'll just kind of walk through fitting the TLSO to our mannequin and point out some reference points and some things that we do when we fit these, and some things that you want to keep an eye on when you're putting them on and taking them off on multiple occasions during their stay. Patient starts in supine. Identify the side of the IV and the drain. Sometimes they're opposite. The big key is you want to roll away from the drain so you're not catching the drain with the posterior shell of the TLSO and then inadvertently pulling the drain out when you're fitting these if it's a post-surgical application. We'll use standard log roll technique. We'll ask the patient to log roll. We'll use the posterior section first. And our key markers are the waist screws. These are little indentions in the foam that are very easy to touch and feel. Our target area is the soft spot right above the iliac crest and below the inferior costal margin, and that natural soft spot that we all have. Now Betty's been working out, so she's pretty trim and it's very defined. Sometimes with our patients it's not quite as easy to palpate, but our target area is right above the hip bone. We'll identify that alignment on our patient, and that's when we slide the post section in. Keeping an eye on the space between the armpit and the foam. We want to have a few finger breadths to make sure that we're not all the way up here in the armpit. This is going to be too high and be very uncomfortable for the patient when they sit. Again, we need it slid down nice and low right above that key marker of the iliac crest. We'll ask the patient and assist them to roll back flat. At this point in time, we're going to eyeball our position, make sure everything looks like it's in approximately the right spot. We're going to look at how much foam is visible on either side to check our symmetry. If the TLSO gets rotated and you can see a bunch of foam on one side and very little on the other, you're best off taking a little bit of time and pulling on the TLSO, getting it situated so that you're somewhat symmetrical. Doesn't have to be perfect, but the closer you are to being equal, the better. The next part is simple. We're just going to apply the anterior section. Anterior section goes over the posterior section. That's how the device is fabricated, and it allows us to compress and tighten this up to the maximum degree. If you get them flipped and you put the inside over, it's not the end of the world. It's just you're not going to have as much adjustability, and it's not necessarily how the device was designed to be used. So anterior over posterior. We're going to start at the bottom to tighten this. The bottom two Velcro closures need to be very snug. This isn't a fracture situation. Imagine it's a long arm cast for somebody that's got a broken radius. They're not going to put that cast on loosely. It's going to be snug. We want to try to hold the bones in proper alignment and prevent them from moving. On patients that have shall we say, some redundant tissue down in this area, by tightening it up first in the bottom at the inferior aspect, we can control some of that tissue and push it up as we tighten. If somebody has a lot of redundant tissue and we start at the top and work down, we're going to push all of that belly out through the bottom of the brace, and it's going to make sitting very difficult. We'll work our way up. Comfortably snug. Again, we're trying to reduce motion and provide stability, so it has to be tight. We'll work our way to the top. On a female, the top closure does not have to be quite as tight. We want to have a little bit of expansion for breast tissue. So as we sit the patient up, the breast tissue has a place to funnel and settle. If we crank these top straps down too tight when they're supine, we run the risk of having breast tissue getting caught in the axilla. So comfortably tight at top, a little bit more snug as you go down the device. Once the device is on, before you sit them up, and this goes for the Aspen LSO as well, you need to look at the patient's position in the bed. We need the patient's anatomical hips to be at the point where the bed hinges. The patient slid too far down in the bed and their toes are hitting the footboard. As soon as you elevate the bed, you're trying to bend the person right through the middle of the spine, typically where they've had either their fracture or their surgical instrumentation placed. So the patient will need to be slid up as high in the bed as possible to align the hips to the hinge point of the bed, and the patient can be elevated. To remove the device, it's simple reverse order of operations. Doesn't matter which strap you use first. Anterior straps will come off. A short log roll, just enough to get the back section of the brace out, and the patient can return to supine. Of note on this device, you can see there's a buffer of foam around all of the plastic borders. That's for comfort, and it also makes for easy adjustment. There are times when we fit these devices, the patients are in CCU, they're not very mobile, and by the time they get to PAL 5, they're starting to start with some mobilization and they're moving around more, and it's not uncommon to have to come down and do a little trimming once these people start moving around. By all means, feel free to call us, that's why we're there. It's not your responsibility to trim and cut on these things. It's just a matter of giving us a holler so we know to check on them our next time we're on the hospital floor doing rounds. In surgical type scenarios, most of the time we're seeing these patients in our office in Clive prior to surgery. We're doing a pre-surgical consult with them, giving them instructions on what kind of clothes to wear to surgery. We talk about the device when they're lucid and they're not on or not recovering from anesthesia. We walk through some of these fitting protocols so they have a baseline understanding prior to waking up at the hospital. We'll also fit them, so we will have a device that is fit and ready to go prior to surgery. Insurance doesn't allow us to provide the device until they get to your floor after surgery. So oftentimes, once they hit the floor, we will watch them on the computer in Epic to get an idea when they're coming out of surgery, and that's when we'll run down to the hospital to get them fit. We work 24 hours a day, 7 days a week, but we don't work all of those hours. So if somebody doesn't get out of the PACU until 6:30 or 7, the device will be there ready for them. We're probably not going to be the first ones to fit it. It will be the nurse or one of the aides on the floor will fit it that evening if the patient wants to get up. Just know that Mark or I or Alex will be there the following morning to check to make sure everything's going okay and to make any adjustments as needed. From a trauma standpoint, those devices are fit on the fly whenever they're needed. And they will always be fit by Alex, Mark, and myself prior to anybody else needing to put them on so we can ensure that they're appropriately fitting. You will hear some nomenclature that might be confusing. This is an off-the-shelf or prefabricated version of a TLSO. We can make these custom to people. Their body shape has to warrant it. They have to be very short and very round, or very tall and very skinny, or have disproportionate breast size to their torso in order to justify making custom. Custom devices take 24 hours lead time. If it's a weekend on a Sunday, you're probably looking at not getting the patient up and moving until Tuesday. So the off-the-shelf devices are identical in function and visual appearance, and they fit 95% of the population. So most of the people we can take care of the same day the order comes in. As far as cleaning care of the foam is closed cell. So it's the opposite of a sponge. A sponge absorbs water. This foam is closed cell, so it repels water. If there's blood or any type of food or anything on it, a warm washcloth, and it should wipe right down. Clothing needs to be worn underneath the device. For males, the hospital gown is just fine. Females with the hospital gown is fine as well, obviously, but when they go home, we'll ask the females to wear a jog bra or to take a jog bra with them to surgery just to help support tissue prior to putting the device on. And that is your bivalve TLSO.